Foxy Falcon is an ex-semi-pro skater who's presenting to the emergency department with crampy diffuse abdominal pain associated with pretty severe nausea, and she started throwing up this morning. Every time she throws up, she feels a bit better, but the vomit is nasty and bitter and green. But what's most distressing to her is that she hasn't pooped or farted for the past 2 days. She's like freaking out about it, dude. She has a history of total abdominal hysterectomy, which was for uterine fibroids. On exam, there's no evidence of peritonitis, but her abdomen is pretty distended and is mildly tender. On labs, she has a mild metabolic alkalosis going on, but nothing really else is wrong. We were asked 2 questions for this case. First, what is the most appropriate first steps for imaging? And then, what are the most appropriate best next steps?
Oh, bro. This skate park is totally tubular, dude. Oh, wait, is that a rock slide in the pipe? Bro, the pipe's totally blocked. Nothing's getting through. Kinda like our clinical case. And this poor little bro dude here, he's totally wiped out, bro. Dude.
I wonder what could be up with them. So, for our clinical case, she's not pooping or farting. So nothing seems to be getting through Foxy's gut, huh? And based on all that vomiting, it seems like things are backing up into her stomach. That's just grody, bro. So, could something be blocking the bowel or, obstructing it? I wonder what sort of things could do that to someone's belly. Let's start this skate park sketch by talking about causes. The small bowel is the most common site of intestinal obstruction in the GI tract, due primarily to its relatively small lumen. It can be either mechanical or functional in nature. Mechanical meaning something is physically blocking the path, and functional meaning abnormalities in the physiologic functioning of the small bowel. We'll start with mechanical, which may be due to extrinsic compression, intraluminal obstruction, or intramural pathologies.
Time to drop in.
The most common cause of small bowel obstruction is mechanical constriction of the bowel by adhesions, which are abnormal fibrous bands just latching onto the side of the bowel. Like this guy grabbing his buddy's shirt so he doesn't fall. The small bowel can get all caught up and twisted on these, causing external mechanical constriction. Adhesions develop in response to surgery or inflammation in the peritoneal cavity. The most common cause of adhesions is prior abdominal or pelvic surgery, with 80% of patients with SBO from adhesions reporting a history of intra-abdominal surgery. The classic history for these patients is intra-abdominal surgery, even if the surgery was many years in the past. We're talking any intra-abdominal surgery, but especially colorectal surgery, appendectomy, gynecologic surgery, or cancer resection. Want me to say it again? Intra-abdominal surgery.
Whoa! It's like they knew what our clinical case was. Huh. Trippy, man. Remember that Foxy had abdominal surgery? Whoa, bro.
In fact, hysterectomies are commonly the only surgery someone will have when presenting with an SBO. But I bet there's other causes of SBO too. Let's keep going. Although the 3 most common causes of adhesions are surgery, more surgery, and even more surgery, adhesions can develop in patients without a history of intra-abdominal or pelvic surgery. Even without a history of surgery, adhesions remain a common cause of SBO. Other causes of adhesions include a history of peritonitis, malignancy, endometriosis, or even inflammatory bowel disease. Infection from diverticulitis, appendicitis, or intra-abdominal abscess may also cause adhesions. Patients who report a history of intermittent obstructive symptoms that resolve on their own and then sometimes recur are more likely to have adhesive disease as the cause of their obstruction. Kind of like those parking spot signs with intermittent times when parking is or isn't allowed, so that you never know when you're gonna end up with a parking ticket.
Dang, bro. I was only running in for a second and it's $170. That could buy so much weed, bro.
This is in comparison to partial chronic small bowel obstructions, but we'll talk symptoms in a little bit. We didn't really get into this history in our clinical case, but if pressed, Foxy may have reported a history of similar mild episodes that lasted a day or 2 and resolved on their own. Tumors are the second most common cause of obstruction after adhesions, in about 20% of cases. This can be from a primary small bowel tumor or from peritoneal spread of malignancy. Primary tumors are more rare and include carcinoid, small bowel carcinoma, and lymphomas. These tumors resulting in obstruction are predominantly metastatic disease, which can either be from peritoneal implants from colonic, ovarian, pancreatic, or gastric cancers, or intramural in the wall from melanoma, lung or breast cancers, or sarcoma. The bottom line here, however, is that if a patient presents with a small bowel obstruction without a history of surgery or other common risk factors, you must suspect that they have a tumor until proven otherwise. Next to our intermittent parking sign is also a kid trying to bulge his way through the gap in the fence, reminding us that hernias can also cause small bowel obstruction. In fact, they're the third most common cause of an SBO. When the hernias are reducible, they can cause intermittent obstruction that resolve when the hernias reduce. But when the hernias are no longer reducible, meaning they're incarcerated hernias, they can cause acute small bowel obstruction. Incarcerated hernias are the leading cause of complications of bowel obstruction, by which I mean ischemia, necrosis, and bowel perforation. A special kind of hernia, called an internal hernia, may also result in small bowel obstruction. These are holes in the mesentery, which can be acquired or congenital, which small bowel can slide into and then become obstructed. Acquired internal hernias are most often due to surgery, where an opening is made in the mesentery, typically in a Rowaney procedure, such as during gastric bypass or a Whipple procedure. Ileal conduit procedures may also lead to internal hernia. Intramural hematomas, similar to this large red backpack, in the wall of the small bowel, usually result from blunt abdominal trauma and may also cause small bowel obstruction. Either early after trauma, the hematoma may bulge into the lumen, or late after trauma, fibrosis of the hematoma may result in gradual stricturing of the lumen. This is most common in the duodenum because it's in a fixed location and may be compressed against the spine during the trauma.
Whoa, dude! Check out this kid's board, dude! Doesn't it remind you of a strictured lumen of the small bowel? And that light looks super radical. I'm talking like radiation.
Other causes of stricture formation, and therefore narrowing of the lumen of the small bowel, may also result in small bowel obstruction. These include Crohn's disease, certain medications such as NSAIDs or potassium chloride, sites of prior anastomoses, radiation therapy, and mesenteric ischemia. Stricture will typically result in chronic symptoms, such as chronic partial obstruction. Volvulus of the small bowel may also cause obstruction, where the small bowel twists itself around a fixed point, like this twisted up hunk of rebar. To learn about large bowel volvulus, check out our mountain climbing sketch covering volvulus and Ogilvie syndrome. In the small bowel, volvulus typically occurs due to abdominal surgery or procedure that has changed the intestinal anatomy, or due to tumors. Volvulus results in acute small bowel obstruction and often what is called a closed loop obstruction. We'll get to that later, but remember the term. It means bad news.
Whoa, sick camera, dude! It's like telescoping.
That reminds me of intussusception, where small bowel telescopes into itself. And guess what? That can cause obstruction too. It's typically seen in pediatric patients, but we'll save that for the Sketchy Peds course. In adults, it can be due to diverticula, like a Meckel's diverticulum, from surgery with intestinal anastomoses, or from tumors. Finally, did you know you can get gallstones stuck in your intestine? It slips out when the fistula is made between the gallbladder and the small intestine. The stone tumbles through the intestines, causing intermittent recurrent obstructions, then lodges somewhere, like the ileocecal valve, and causes complete acute obstruction. Check out our cholecystitis video for more on this topic. All right, well, we have a pretty good reason for Foxy from our clinical case to have an obstruction. Let's look at the clinical presentation next and see if this is actually what she has.
Oh, this dude's about to vom, guys. Watch your chucks.
Symptoms of small bowel obstructions typically include nausea with emesis, which can be either bilious or feculent, cramping or colicky abdominal pain, and constipation progressing to obstipation, which means the inability to pass any flatus or stool. Be sure to ask when the last time they pooped and farted was.
Bro! Foxy Falcon from our clinical case definitely seems to have these. She's blowing all kinds of chunks and nothing's coming out the other end. Oh.
These symptoms are variable depending on where the obstruction is and whether it's a partial obstruction, which results in milder symptoms, versus a complete obstruction where the symptoms are much more severe. The character of pain may also help describe what's going on. Mild, vague, and crampy is typically early in the disease. If pain is more constant and more focal, this may indicate peritoneal irritation and development of ischemia or bowel wall necrosis. And finally, sudden onset severe constant pain may indicate perforation. Next, we'll talk about the physical exam. Remember what the findings were in our clinical case? I'll bet they'll come up here. Abdominal distension may be marked, and you may be able to see this from the door. Yep, just as I thought. This sounds just like our clinical case from the beginning. This is more common in distal obstructions, where the bowel proximal to the obstruction fills up with accumulating fluid and air. Typically, distension is much less in proximal obstructions, but nausea and emesis will be more severe.
Oh, yeah, beat those drums, girl.
Along with the distension, there's often the sound of high-pitched bongo drums, called tympany, when the abdomen is percussed. This gives us the classic physical exam description, tympany to percussion. Dullness to percussion indicates fluid-filled areas. If there's acute pain with percussion, this suggests peritonitis and possible bowel perforation. You should also look for surgical scars and palpate for abdominal wall hernias. Surgical scars on the abdomen alert you to likely adhesive disease, and hernias may be the cause of the obstruction or may be uninvolved in the obstruction but just prominent due to the abdominal distension.
The clinical case didn't mention it, but I'll bet Foxy has a gnarly scar from surgery.
On auscultation of the abdomen, you may hear hyperactive bowel sounds, which are like tinkling sounds like stones falling in a metal pipe, with longer, intermittent silent times. The tinkling noise is from air bubbles within the lumen bouncing around as the bowel attempts peristalsis. As the obstruction process continues, the bowel stops attempting to peristalse and bowel sounds become hypoactive.
Careful there, dude. That's my tailpipe.
Digital rectal exam may reveal fecal impaction or rectal mass that may be the source of obstruction. Typically, this would present as a large bowel obstruction, but may sometimes be difficult to distinguish on clinical exam alone. Blood on digital rectal exam, either occult or frank hematochezia, may indicate an intestinal tumor, inflammatory condition, presence of bowel ischemia, or intussusception. As obstruction continues, metabolic alkalosis results, and labs are an important diagnostic test to get early in these patients. The bowel wall becomes edematous, pulling fluid out of the lumen of the bowel. This is called third spacing. With all that fluid clogging up the cells in interstitial space, the bowel wall loses its absorptive function. This, plus continued vomiting, results in an overall dehydrated state. Contraction alkalosis occurs due to activation of the renin-angiotensin-aldosterone system. Remember that with loss of hydrogen and chloride ions during emesis, the body becomes alkalotic as well.
Oh, so that explains what's up with Foxy's labs from her clinical case. Righteous, bro.
This metabolic alkalosis will typically increase the renal excretion of potassium in order to salvage hydrogen ions to counteract the loss of gastric acid. Increased serum aldosterone from the RAS activation will also contribute to potassium losses. Another important consideration is the location of the obstruction. The symptoms may give some clues. Distension, obstipation, and hyperactive bowel sounds typically suggest a blockage in the mid or distal small bowel. On the other hand, if a small bowel obstruction is more proximal, like in the duodenum or proximal jejunum, there will typically be less distension and less change in bowel habits, but more vomiting and a shorter time course from when symptoms started to presentation. In this case, intestinal contents just don't move as far, and they have less room to back up and cause distension. But when they do back up, there's a shorter distance back to the stomach, and then, well...
Ugh, that's just nasty, bro. But you gotta do what you gotta do. Oh, classic graffiti, bruh. Sick hair, too.
The most classic imaging finding for a small bowel obstruction happens on an upright x ray: dilated air fluid loops of bowel with multiple air fluid levels. These clouds here are a bit reminiscent of the gas pattern seen on an x ray. With an x ray, you can also quickly see whether there are concerning findings that would indicate emergent intervention, including abdominal free air, such as air under the diaphragm, or cecal or sigmoid volvulus. The next few terms we're going to use you've probably already heard a few times. Partial obstructions typically present with less severe symptoms, such as nausea but maybe not so much emesis, or constipation, but they may still be passing a little flatus. On imaging, the small bowel after the area of obstruction is decompressed, but typically there is still stool and gas throughout the colon and rectum, which can be seen on x-ray. Complete obstructions typically have more severe symptoms, like aggressive emesis, prominent distension, full-blown obstipation, and on imaging, the bowel distal to the point of the obstruction will be very decompressed, such as this little crack representing decompressed bowel. This will appear like a lack of stool and gas in the colon and rectum on x-ray as well. In a bowel that's completely filled with fluid, there may be pretty minimal gas seen on x-ray. You may only see little blips of gas in a characteristic string of beads sign, kind of like these raindrops are making, as air collects along the top part of the small bowel loops.
Oh, sick! Dudes and dudettes! I think we have the answer to our first clinical question. Let's get Foxy over to that x-ray room and shoot some pics of her belly. Yeah.
X-ray is helpful for a quick diagnosis. But to be honest, it's not going to tell you exactly where the obstruction is or what's causing it. For that, we use CT scan if the patient is stable and there are no signs suggesting perforation or indicating emergent intervention.
Aw, you're kitty kitty. Look how stable this little guy is on his cute little skateboard.
CT scan will show you the dilated loops of bowel as well as air-gas interfaces, and you'll be able to see distal compression of bowel easier. But the major thing that CT is going to do is locate the point of obstruction. This is called the transition point, or the point where the obstruction actually is. Think of this as the point where the bowel transitions from dilated to decompressed. The transition point may be all you see, but with tumors and hernias, which we remember are the second and third most common causes of SBOs, you can actually see the tumor or hernia involving the transition point, giving you the cause of the obstruction. Yay! Other things you may see are bowel wall edema, mesenteric edema, ascites, a target sign, which is alternating layers of bowel and indicates intussusception, or whirling of the mesentery, called whorl sign. Whorl sign can be seen on CT with contrast, where the vessels running through the mesentery make a swirl as you pan back and forth through the scan. It indicates a twist, volvulus, or internal hernia. CT may also show signs of impending doom. By this I mean impending ischemia, necrosis, and perforation. Check out this totally tubular graffiti over here as we talk about how to identify bowel wall at risk for this. The bowel wall has blood vessels running through it, and if there's an area that's not receiving blood flow, it can become ischemic. And we all know how that path ends. When blood with IV contrast goes through the bowel wall, this causes contrast enhancement of the bowel wall so that it looks lighter than surrounding tissues and thus identifiable on CT scan. And this means you can see the areas that have decreased blood flow, where the contrast isn't lighting up the wall as much. To describe these areas, you'll hear the term non-enhancement, which means these areas are at risk for necrosis and already becoming ischemic due to reduced blood flow. So even though for our clinical case, the first imaging study should be an X-ray, we should also get a CT scan of Foxy's abdomen. All right, after imaging, particularly CT scan, has demonstrated what's going on with our patient, the next step is actually doing something to help the patient.
'Cause you gotta actually do something now, bro.
If the history, physical exam, and CT scan do not show any big red flags, and there's no evidence of complications such as peritonitis, then a non-operative management approach is the best next step. This means admission to the hospital, most appropriately to the surgical service, bowel rest, and G-tube decompression, intravenous resuscitation, and careful serial observation. It's important to note that many of these same measures are taken in the preoperative period for patients that are going immediately to surgery as well. And I think we have the answer to our second clinical question. Totally righteous. All of these things are important not only for patients undergoing a non-operative trial, but they're also necessary in patients that are going to surgery. We've already talked about the volume depletion from third spacing and metabolic alkalosis and electrolyte abnormalities that can result from small bowel obstruction. Now let's correct them. Intravenous fluid is paramount to correcting these metabolic derangements in these patients. Typically, patients should be bolus to correct the volume depletion. Several liters of lactated ringers or normal saline may be required in severe volume contraction, and then maintenance fluid started. Serum potassium should be carefully repleted with attention paid to the patient's kidneys, particularly whether acute kidney injury is present. Patients with SBO should be made NPO, or nil per aus in Latin. NPO status fulfills several roles. When not eating or drinking, patients will often have partial or sometimes even complete relief of their nausea and emesis. Bowel rest will also help reduce bowel wall edema. And when combined with NG tube decompression, NPO status helps to keep the GI tract relatively empty, which may even reverse the obstruction.
Ha, that's gotta totally hurt coming out of your nose, bruh.
A nasogastric tube should be placed for proximal decompression. This also serves several roles. First, patients will very often have immediate relief of at least some of their nausea and distension symptoms. However, after the initial relief, you may need to spend the next several days convincing your patient to keep the tube in. Next, NG tubes can decrease the amount of bowel distension occurring, which is helpful if a patient eventually needs surgery. Finally, NG tubes may even help reverse the obstruction. Once all of the fluid is sucked out of the lumen, the bowel is empty and decompressed and can even untwist itself. It's very important to continue fluid resuscitation and electrolyte repletion while the NG tube is in place. Think of the NG tube as a source of continuous GI fluid loss. Sometimes fluid will need to be replaced based on the volume output from the tube. A patient's ins and outs should be monitored very closely.
What? The park is closed for 5 whole days? Come on, bro. That's just not cool, man.
For uncomplicated cases with no red flags on history, exam, or imaging, patients can be watched for several days, awaiting return of their bowel function. This requires careful and frequent serial exams to ensure that patients are not developing complications so as to not delay operative intervention if warranted. However, after approximately 3 to 5 days of non-operative management, if a patient is not progressing, patients will often undergo surgical exploration, as after the 3 to 5 days, the morbidity and mortality of continued observation begin to increase. After 48 hours of observation without resolution of the obstruction, contrast imaging studies are often performed. After the contrast is administered, usually down the NG tube, serial X-ray images every 1 to 2 hours are taken to follow the progress of contrast along the bowel. This is often called a small bowel follow-through and serves 2 roles. 1. The images show whether the contrast can make it to the bowel, and if it does, how long it takes to get there. If the contrast makes it to the colon fast, the obstruction is considered to be resolved. If it makes it to the colon slowly, then there's likely a component of partial obstruction still occurring. But typically, non-operative management is still appropriate. If it doesn't get to the colon within 12 to 24 hours, the obstruction is most likely complete, and most often the patient will require surgery. And 2. Gastrographin, which is the contrast of choice, is osmotically hypertonic, meaning that while it sits in the GI tract, it pulls fluid out of the edematous bowel wall and into the lumen. In many circumstances, this helps resolve the obstruction. Another effect of the fluid shift is that, once the obstruction is resolved, the fluid in the lumen can progress very quickly through the colon and into the rectum, and out of your patient as some major diarrhea, making the return of bowel function pretty obvious.
Ugh, kid, get out of that stinky mud. Definitely don't be eating anything when you're in there. Ugh, gross, man.
Resolution of a bowel obstruction is signaled by a decrease in the NG tube output, as well as return of bowel function in the form of flatus and/or passage of stool. oftentimes diarrhea. Kinda like what maybe happened with that kid over there. Typically, the NG tube is then removed, and a diet is initiated and advanced as the patient is able to tolerate. Once tolerating a regular diet and having regular bowel function, the patient can be discharged if there are no other active issues for the patient. However, it's important to remember that there are certain indications that would require urgent and emergent operative management. It's important to remember that these can develop at any time during the disease process, including when a patient is undergoing a trial of non-operative management. Just because your patient seems benign when you admit them to the hospital does not mean they'll still be the same in 4 to 6 hours. Patients need serial exams to ensure they're not developing complications that would require surgery, such as bowel ischemia, necrosis, and perforation.
Dudes, get your scalpels ready.
You may remember this Mexican skull symbol from our acute mesenteric ischemia videos. Remember that as ischemia develops, the patient will begin to clinically deteriorate. Abdominal pain becomes worse and, if perforation is present, may progress rapidly to peritonitis on exam. Fever and tachycardia may develop in response to the infarcting bowel wall. Leukocytosis and acidosis also develop. The patient may be hemodynamically unstable as they progress into sepsis and then into shock. While severe cases are obvious, early ischemia may be difficult to diagnose, and thus vigilant serial exams are required in high-risk patients. On imaging, perforation may be demonstrated by air under the diaphragm on X-ray. This is seen as black bubbles of air just underneath the opacity of the diaphragm, just as this kid has his black underwear on underneath his diaphragm. Although unstable patients should not get advanced imaging such as CT, it may be necessary in confounding cases. CT scan in cases of mesenteric ischemia may demonstrate non-enhancement of bowel wall, free air or fluid within the peritoneum, pneumatosis intestinalis, or air in the bowel wall, or portal venous gas. These are late occurring signs seen in severe cases, so they may not be seen even if early ischemia is occurring. The whole clinical picture needs to be taken into account when concerned for ischemia, necrosis, and perforation. 2 other important indications for surgery are complete small bowel obstructions and closed loop obstructions. Complete obstructions, as we talked about earlier, typically have worse symptoms and are more likely to be associated with complete obstipation. However, stool and gas distal to the point of obstruction may still pass through the patient even after obstructive symptoms have started. Complete obstructions can also be identified as contrast unable to pass through to the colon on small bowel follow-through. Complete obstructions are more likely to result in the need for surgical intervention and are associated with higher morbidity and mortality, independent of etiology. A closed loop obstruction is a specific type of complete obstruction where a loop of bowel is obstructed in 2 locations, oftentimes from twisting around on itself. This is an indication for emergent surgery because the blood supply to that area of bowel is cut off, and it can very quickly lead to complications like ischemia, necrosis, and perforation. Initial symptoms may also be very mild, as only a short segment of bowel may be obstructed and distended. Imaging may demonstrate a distended and fluid-filled loop of bowel, often in a C or U shape, typically with decompressed bowel on either side of the transition point. Whorl sign is also often present. Hernias causing small bowel obstructions also complicate the decision-making algorithm. With an obvious and surgically correctable cause of the SBO, these patients may require surgery even if they aren't displaying signs of complications. SBOs caused by incarcerated hernias also have a higher rate of complications than SBOs caused by adhesive disease. Since the last 2 special cases for SBO are very different than the rest in terms of management, here's the best place to talk about surgical intervention. We went over a pretty extensive description of the surgery in our acute mesenteric ischemia sketches, particularly our second one. If you haven't had the chance, check both of those sketches out. They're dead fun. Yeah, get it? Because their theme is the Day of the Dead, and we're talking about dead bowel. Yeah. We're going to highlight the basic steps from that sketch as we talk about surgical intervention for SBOs. Typically, surgical intervention for SBO is approached from an urgent or emergent basis. Usually, exploratory laparotomy is performed. However, at specialized centers, laparoscopic surgery may be performed. There may be rare occasions that elective adhesiolysis may be performed. If simple adhesions are the cause in an uncomplicated patient that simply fails to resolve, or if there's a single band likely causing the obstruction, adhesiolysis may be performed, which involves cutting the adhesive bands involved. More extensive cases may take much longer to sort out the best way to resolve the obstruction, including resection of the involved bowel and reanastomosis. Once the area of obstruction has been identified, the bowel is inspected. Any frank necrosis is resected. Viable bowel can be identified by the presence of normal bowel wall color, active peristalsis, bleeding from cut surfaces, and arterial pulsations in the mesentery. Questionable bowel can be left, and the patient taken back 24 to 48 hours later for a second look operation. This is a common method in critically ill patients who cannot tolerate extended anesthesia. Another special case for surgery is Crohn's disease. In this case, because Crohn's disease is a chronic inflammatory illness, we want to resect as little bowel as possible and avoid surgery altogether in favor of medical treatment if possible. The underlying inflammation needs to be tightly controlled medically and given a chance to resolve the obstruction prior to surgery being performed. This being said, SBO from stricturing due to Crohn's disease will often still need surgery. For more information on the medical management of Crohn's disease, even in the case of small bowel obstruction, see our sketch on Crohn's disease along the Oregon Trail if you haven't already. The last special circumstance we're going to talk about is SBO due to malignancy. For the most part, patients with SBO from malignancy can follow the algorithm of non-surgical management as we've discussed, moving to surgery if there's ischemia, necrosis, or perforation, with an expected higher rate of failure of non-operative management, morbidity, and mortality. Malignancy may either be primary or secondary, with peritoneal metastasis being a common cause of SBOs in patients with advanced cancers. Malignancy can cause adhesions, as we've touched on. Sometimes solitary tumors can be resected, both for the treatment of the malignancy and, in advanced cases, palliation. Other palliative and not curative options include small bowel bypasses to divert flow of GI contents around the obstructions, or ostomies to divert flow of succus out of the patient before it can reach the point of obstruction. If the tumor is located in the duodenum, stents can be attempted to control symptoms. Venting gastrostomy tubes may also be considered, particularly for recurrent SBOs due to extensive peritoneal metastasis, where a percutaneous endoscopic gastrostomy, aka PEG tube, is placed, which can be opened to vent the stomach when obstructive symptoms occur. However, all of these have their own set of complications and failure rates. Dudes, we're done! Great job, everyone! We're all finished up with small bowel obstructions. Let's review. The small bowel is the most common location of intestinal obstruction in the GI tract. This is due to the small lumen. Obstructions may be mechanical or functional in nature. Adhesions are the most common cause of an SBO, and previous abdominopelvic surgery is the most common cause of adhesions, making previous surgery the most common cause of SBOs. Adhesions may also develop from inflammatory conditions such as malignancy, peritonitis, inflammatory bowel disease, endometriosis, or infectious conditions such as diverticulitis, appendicitis, or abscess formation. Adhesive disease is associated with intermittent recurrent small bowel obstructions, which may resolve on their own, as compared to chronic partial small bowel obstructions that may cause more consistent but very mild symptoms. Malignancy is the second most common cause of small bowel obstruction and can be either primary tumors or cancer metastatic to the peritoneum. Hernias are the third most common cause. Reducible hernias may cause intermittent symptoms, whereas incarcerated hernias can cause acute small bowel obstruction. Incarcerated hernias are the most likely of all causes of SBO to result in complications such as ischemia, necrosis, and perforation. Other causes include internal hernias, either congenital or acquired due to surgery, hematomas, such as in the duodenum, and other traumatic injuries, strictures from Crohn's disease, radiation, or surgery, volvulus, intussusception, and gallstone ileus. Symptoms of SBO include cramping abdominal pain, nausea, emesis, constipation or obstipation, and physical exam may demonstrate abdominal distension, tympany to percussion, hernias or surgical scars, intermittent high-pitched hyperactive bowel sounds, fecal impaction, or hematochezia. On labs, patients may have evidence of significant dehydration, including contraction alkalosis and hypokalemia. X-ray may demonstrate air fluid levels and/or dilated and air-filled small bowel loops or string of beads sign, whereas CT scan may be able to identify the location of the obstruction more accurately, as well as give clues to etiology, such as tumors, and identify complications, such as ischemia, necrosis, and perforation. Treatment of an uncomplicated SBO is typically non-operative, with NPO status, IV fluid resuscitation, electrolyte replacement, and NG tube decompression with observation and serial exams for 3 to 5 days. Patients may undergo small bowel follow-through with contrast through the NG tube for evaluation of the ability and speed of contrast to progress through the small bowel and into the colon. Gastrographin is hypertonic and may pull fluid into the lumen of the bowel and may help resolve the obstruction. Red flags that may identify patients that might need emergent or urgent surgical exploration include evidence of ischemia, necrosis, and perforation, such as peritonitis, fever, tachycardia, leukocytosis, acidosis, hemodynamic instability, air under the diaphragm on imaging, or other imaging findings of complications. Complete obstructions and closed-loop obstructions are more likely to become complicated and need surgical exploration. Hernias, especially incarcerated hernias, are the most likely cause of SBO to cause complications and are more likely to require surgery. For the complete details on exploratory surgery, check out our acute mesenteric ischemia sketches. Crohn's disease and malignancy are two other special circumstances of SBO where surgery is delayed until absolutely necessary. Check out our Crohn's disease sketch for more information in Crohn SBOs. In cases of malignancy, there are palliative surgical options as well as the typical surgical options. This sketch isn't done though. Head on over to the next video for part 2, ileus.